Hello, my name is Dr. Jeffrey Barsuk. I am the Robert Herstick Professor of Medicine and Medical Education at Northwestern University Feinberg School of Medicine. I currently serve as the Executive Medical Director of Northwestern Simulation. I would like to welcome you back to another podcast in our series on simulation and healthcare education. Today, I have the distinct honor of interviewing Dr. Haru Okuda. Haru currently serves as the Executive Director of the University of South Florida's Health Center for Advanced Medical Learning and Simulation. He also serves as the President for the Society for Simulation and Healthcare. We will be discussing the important initiatives and future plans of the Society for Simulation and Healthcare. Haru, it's an honor to interview you today.
Jeff, I really appreciate you inviting me. I'm looking for the conversation.
So I usually start the podcast with a little bit of background about yourself and how you got involved in simulation.
Okay, happy to share. I know you and I go way back, and we both have a passion for simulation and patient safety, and so you probably wouldn't be surprised that my story roots back into an error in medicine. And I won't go too far into it. I think I've shared this to multiple folks in the past, but going through. Even prior to medical school, I trained in classical music, and I learned deliberate practice probably before Anders Ericsson coined the term deliberate practice. That's just how I thought people in professional skills should learn. And then fast forward to medical school residency, and I trained over 20 years ago. It was the see one, do one, teach one time, and then during that time, multiple situations where patients were at risk because of the see one, do one, teach one lack of supervision. And, my one was around central line placement, where my resident supervisor when I was an intern, even though I asked for help, he didn't come help. And he said, you do it on your own. And back then we didn't question. I did. I left the guide wire in after I took the central line out. Fortunately, there was no harm to the patient, long-term harm. The harm was, they had to get another central line placed. But since then, simulation has been my passion, trying to really figure out how do we train our healthcare workforce in a safer way using deliberate practice, mastery learning. And I think, that's really been my career focus around patient safety and quality improvement. And that's why I many years ago, I reached out to you and we collaborated when I was with the VA, because I really appreciate the work that you had done in Central Line at Northwestern in real, true mastery learning, deliberate practice. And so we shared that time together many years back.
And I think I have a similar story to yours, although fortunately there wasn't the complication, but I can remember my first subclavian central line insertion, and it was similar to that, is that there was no supervising physician anywhere to be found. And I can remember literally the up-to-date chapter being open at the bedside as we looked at the anatomical pictures to try and figure out what we were doing. Fortunately, we did a successful line, but it's embarrassing to know that we once practiced medicine that way and it was okay. And now it's not okay to practice for the first time on patients for the better.
Which is great, yeah.
So now you have a new role, a relatively new role, and you're the president of the Society for Simulation and Healthcare. And there's a lot of important initiatives going on. Can you give me some overview of what you see in the future for the Society under your leadership?
Happy to. So the Society position is a 1-year term, though, I get to be involved for another year after my term ends at the end of the IMSH conference in January of 2023 as past president. But probably to no surprise, my focus is on patient safety. And I think the Society has, over the 20 plus years, has done some incredible jobs, has done an incredible job in teaching in the science of training and education, the methodology of it from a educational standpoint, things like deliberate practice, defining what simulation is, all the modalities. And I think throughout the organization, there is some great work being done from the members in patient safety and quality improvement. But, I don't know if we've taken as a society a more collective, organized approach to patient safety and quality improvement in terms of advocacy. And so that's an area that I've always been passionate about. And the reason is, we often we maybe we joke or we say we often are, we're preaching to the choir, or we're all the same folks that drunk the same Kool-Aid. But at many times in many institutions, whether you work in a hospital, healthcare system, simulation aficionados or folks passionate in simulation lack the resources, lack senior level support, lack access to learners, not doctors, nurses, to do the training because, maybe leadership doesn't endorse it, or maybe there's no funds. And so my thought is if we can try to get a couple of things, both in terms of either state or federal policy around the use of simulation for patient safety, if we can maybe get some funding, some grants around patient safety. We used to have some funding around HRQ. I'm sure you remember those days, and that was taken away. And so I think the society has, over 5,000 members. We have a great voice, and I think we have a great opportunity to truly advocate in this area. So I have stood up a government advocacy task force. It's at the president's level. Leading it is Bob Armstrong, past president, who comes from the military background, understands government. And we've been working with multiple groups to try to get in front of people that decide laws and decide where federal funding is going to be on Capitol Hill, to try to really educate and advocate around the use of patient simulation for patient safety. I would say we're not going as far as lobbying, but we're doing everything we can in order to really help folks understand the importance of it. And I think at the end of the day, when I have conversations, and when I was wearing my National Medical Director hat for the VA simulation program, I spoke to many representatives and Congress people, and when you talk about it, they're all 100% on board. They're like, "This is really important. We should be doing this," and all of that. So I think we just need to make it a priority, help them make it a priority, and have a collective voice in really pushing this agenda forward. So that is one of my main goals, and I hope I can. It's not going to be done at the end of my term. So obviously, my hope is to carry this along as my past president role next year. The other area that, especially with COVID, has come out being very important is around new technology for training and education. And especially, as I mentioned, with COVID, it's forced a lot of our face-to-face training for, 1 or 2 years to virtual, Zoom, Teams. They're helpful, but they're not going to replace hands-on simulation-based training, whether it's procedural training, team training. And we've seen a lot of new technology come out in the experiential learning area, things like virtual reality, augmented reality, mixed reality. And having learned from my mistakes, hopefully about 20 years ago, when lots of really cool toys came out, and I said, "Oh, we'll buy some of those things," and really trying to, at that time I was like, "Well, we'll buy it and figure out where it fits." Want to take a much more collaborative approach to the development of new technology. We as subject matter experts, whether we're simulation experts or clinicians, working with corporations to help define our gaps and then help them develop future technology that'll meet our needs. And so we're working with our corporate roundtable members to see if we can come up with maybe almost like a consensus conference or some meeting where we would discuss those things and have hopefully like a white paper that can help define a roadmap for technology for training and education. So those are two of the main initiatives that I'm passionate about this year. The third one that we'll be working on is equally or more important, our strategic planning for the next 5 years. The society has had a 5-year strategic plan. It ended in 2020, COVID hit. So the two past presidents had put a halt on a future strategic plan until we sort of normalize that we were, continue to talk about the new normal. And now I think we are at that point where we need to have another 5-year strategic plan. And so the board is going to meet in the fall to get this going. And we've already sent out some surveys already, and we're going to seek input from the members to figure out, where the organization needs to go 5 years from now.
So Haru, if we can, I wanted to delve into a little bit more of some of these important initiatives, and certainly we're not going to be able to say much about the strategic planning until it really happens. Mm-hmm. But I want to delve into a little bit more about what you talked about with advocacy, and then we'll get into new technology. You had mentioned that for advocacy and talking to Congress, trying to get more funding for training and education. But you also recognize that the problem is that sometimes it's not just that the hospitals don't know how to do it, but they don't have the money to do it. And we've seen a lot of literature in simulation about return on investment. And in fact, I was struck by the IMSH plenary session this year given by Paul Frampus, where he really talked about this problem in and of itself, that despite we're over 10, 15 years from some landmark studies that showed patient outcomes and return on investment, yet we're still not there yet. And I wonder if any of that advocacy also might result in new laws through Congress about how physicians are trained, or maybe that's too granular for Congress. And maybe it's about going to the joint commissions or going to the AAMC or going to the ACGME to get new rules for how we train clinicians.
Yeah, it's a really great question. I think it's frustrating for those of us who have been doing this for a couple of decades. Paul and I I've known each other for quite some time, and he's been really leading this effort at his shop at the University of Pittsburgh. I think he even has a patient safety title for the system. And as you alluded to, I think there are the main challenges to implementing simulation-based training in these large healthcare systems is that oftentimes the incentives for these healthcare systems aren't aligned with training education focused around patient safety. And it's not a dig to healthcare organizations, but when you have limited resources, limited time, you have rising costs, and these organizations, whether they're profit or non-for-profit, are trying to make the ends meet. Increasing costs for, it does cost money to run simulation, whether in terms of equipment, staff, probably even more challenging is opportunity costs for a hospital. So, backfilling nurses, physicians to do training. If they're not doing training, they could be seeing patients, which ultimately generate revenue. And so I think those have really intersected in really help in a negative way to propel simulation-based training in these organizations. And so then, you asked the question, would it help to create laws or requirements, the stick part at, the federal level or joint commission level, et cetera. And I think there are some, there are definitely some both pros and cons to that concept. I would say if I were king for the day, and had my magic wand, or maybe the fairy, godmother for the day, I think it makes sense to ensure competency for certain skill sets, especially high risk areas for both graduating physicians. I'm sure there are equivalent things in nursing and other health professions, and then the maintenance of those skills over the course of their career. And I don't think that's too much to ask. I mean, we do that for a lot of professionals. We often reference the airline industry, but there are many others that require that level of evaluation. And I think simulation is the best way to do that. You don't want it to become so onerous that then it prevents people from wanting to practice clinically or to be able to see patients, et cetera. I think I think in terms I've been looking into our most recent series on the podcast that I'll talk about a little bit later is on mental health and burnout in healthcare. And we know the number one cause of that is all the administrative burden that goes to these health professionals. And so if they consider training, education, administrative burden, now we're pushing on the other side. So it's I guess it's a complicated answer. I think it would be great to be able to advocate to at least get simulation on the radar for these large organizations like the Joint Commissions, like ACGME, AAMC. I mean, they are requiring it to some degree, but to really have it as a part of their day-to-day conversation should be a requirement for, I think, all specialties. And if you go to the Joint Commission or IHI, it should be prominent, right? There should be a toolbox on simulation for patient safety. There should be some criteria and best practices for simulation for the Joint Commission. It should be a part of their checkoff. Like, are you doing it? But, I don't think that's still being done as of now. And I don't think it'd be too onerous. I don't think it'd be a lot to ask. And I think the evidence is clear, especially in areas like Central Line and other areas that, there's a significant benefit to the use of simulation for patient safety.
It's interesting too, because you mentioned low resource hospitals that are just barely making ends meet. I'm fortunate enough to have been in an organization that has always done very well financially and has a lot of things at their fingertip that they can do. Mm-hmm. And we've been doing or at least I have been doing simulation here for almost 20 years now. And we are just still scraping the surface about integration within the hospital. And it's hard to come by those resources, even when they're plentiful. Mm-hmm. But, I'll take my victories. I mean, right now, in some of our divisions within medicine, we are requiring simulation-based mastery learning skills to be done for even privileging in the hospital for things like bedside procedure and central line. Mm-hmm, mm-hmm. So it is a big win. And we're even doing some of that with nursing now. But it took 20 years, and that's in a high-resourced environment. So I can't imagine what would happen. And maybe some of the funding has to incentivize institutions that are struggling more, or all institutions for that matter. Maybe they somehow link this to, Medicare reimbursements. I don't have the answer either, but there are certainly financial incentive ways also to link simulation to some of these outcomes.
Yeah, no, I absolutely agree. I think when I worked in policy a little bit when I was at the VA at the end of my time there, and if you create these rules, these laws or whatever you call it, it has to be able to you have to be able to apply it broadly, and you have to be able to implement it in all parts of the country, right? And like you said, if you're having the very wealthy or the major academic medical centers are the ones that are barely doing it because of resources, et cetera. You have majority of the country lives not by a major medical center, and then you would create requirements that those organizations can't meet or are destined to fail, and that's not how you build policy that is sustainable.
But needless to say, this almost segues into the next initiative you were talking about, the new technology, because some of the solution to being resource poor is this new technology potentially creating environments where individuals can train without even needing the time of an instructor. It's all built in. And you mentioned augmented reality and virtual reality. Mm-hmm. My concern always with those technologies is they're not quite there yet because of the lack of haptics. But I always think about what Doug Bagley from Simulab has told me, in that when they created Trauma Man, it was the surgeons that came to them and said, "We have a problem. Can you fix it?" And then they were able to make Trauma Man. And I like what you said, that you're going to have a corporate council where you're going to be able to, bring some of the needs to them and then essentially give them a challenge and say, hey, we need this or this to bring simulation to the future. Is there anything more granular in that you can talk about?
No, we're still in the early planning stages of these discussions. I can say that our corporate partners through SSH are very interested. I think if you speak to every corporation, at least that we deal with, they don't want to create something that nobody's going to use, right? They're in it because all these companies really want to make an impact, whether it's in education, training, or patient safety, quality improvement. But oftentimes they don't have the feedback of the frontline end user. And because clinicians are busy and they may just not be able to give that feedback. And so I think they are eager to hear from not just one person, because I think a lot of times products are made based on one person's expertise, but eager to get input from diverse group of experts that can really define both the needs in a what are the clinical needs that's going to be facing us now and into the future, but what are also the training modality needs, because we are dealing with a new type of students nowadays. I hear deans complaining all the times that their classrooms are empty because they'd rather be at home and study off of the audio at 2.5 times speed or something, or they just don't want to go to lectures anymore. They want to learn in a more immersive environment, or the challenges of COVID, where you need to be able to teach certain things in a distance way, but beyond just the knowledge topics, things to memorize. And then what you alluded to, and we're doing a little bit of this research at USF Camels, is trying to get to the under-resourced areas, rural areas, get them the cutting edge new training and expertise just in time, so that it's not they catch up 5 years later, but when something comes out, it emerges, they're notified and get trained right away. And could you use virtual reality or augmented reality or the metaverse, right? And doing that kind of work. So I think everybody is willing to work together. I think it's definitely exciting times. The healthcare simulation business is a multi-billion-dollar business now. There's a lot of money now, whereas maybe 10, 15 years ago there wasn't. So I think corporations are willing to put some of their investment into really changing, where are we going in the next 20 years for experiential learning.
All right, well, I'm going to segue a little bit into some of your personal work. I know that you are doing a bunch of work in interprofessional team healthcare education. Can you describe to me a little bit about what you mean by interprofessional team education and what you're doing now?
Yeah, so my second hat is the Associate Vice President for Interprofessional Education and Practice for USF Health. And that work is really what we've been doing in healthcare simulation for a long time. We just haven't really put words to it. Where when you and I we learned in silos. We went through medical school. At least I'll speak for myself. I went through medical school really not knowing what nurses did or pharmacists or other health professions did. And then I even went through residency, and I interacted with my nurses, but again, I didn't know what they did. They were folks that helped get medications for me, and it was really revolved around my tasks. But I didn't know that they had a whole. I mean, I should have known, but I didn't know they had a whole other set of things that they did for the patient. And then it wasn't until you became an attending that you suddenly have to be able to work with all these different professions. So, what we're doing at USF Health is really focusing on trying to have our students learn early on together in simulated environments and non-simulated environments, so that they really understand each of the roles and responsibilities that revolve around an individual patient. And then, hopefully that reduces all the the hierarchy that I think traditionally has been there. I mean, back 20 years ago, 30 years ago, the physician was always in charge. And I think, you and I know from team training literature that, team leaders change all the time. It adapts to the situation. There are leaders for certain roles, and sometimes the team leader needs to do a procedure, and some other team leader emerges, and so we're trying to teach those concepts at an early age to our learners, and then what we found out was that it just mirrors my patient safety work, where you teach patient safety to students, they go out to their hospital environments, and then the attendings and residents are like, oh, we don't do that here. That's nice in book practice, but it's not something we practice. And so, the interprofessional practice part is really educating the existing healthcare workforce around the kind of work, the importance of interprofessional teamwork, giving them, an understanding of the types of things that we're trying to teach our students, so that at the minimum, even if they don't love the concept of interprofessional practice, when the students come to rotate in the hospitals or clinics, they understand what we're trying to teach them, and the hopes that in the future, you're going to have much more collaborative teams that really understand work well together, using shared mental models, shared language, whether it's team steps or CRM or those types of things, and then ultimately lead to patient safety and quality improvement. I mean, as you and I know, lots of errors in medicine, whether you look at the RCAs from AHRQ, are related to communication errors. And so if we can tackle that through interprofessional teamwork, interprofessional education, we're hoping that we can, in the future, reduce those types of errors.
And that interprofessional education, it's more than just talking about the concepts, but I assume it's also doing simulations where the whole team is interacting. Historically, it's that we're going to go to the central line mannequin, and it's myself as the instructor and a student working on the mannequin. But ultimately, in reality, in the hospital, when we're putting in a central line, there's more than just the physician involved. There's the nurse and potentially others involved to make that the safest procedure. And in fact, when we did the VA study for the paper that we published, one of the things that we got in our qualitative review and our interviews was that we were missing the nurses from the training, and it kind of speaks to this. Now I have the fortune of doing some in situ simulations in our hospital for cardiac arrests, and I really believe that it's improving the safety culture by allowing, the team to work together. We used to think that training, that we worked in silos, and really, as Bill McGahee says, nobody works in silos. They never have, right? We work as teams,
right?
Not just in healthcare, but in everything we do. You have to recognize that. So it's so important that we get better with this. And you're absolutely right. It's one thing in the book, and it's another thing in practice. And I like to think we're moving in the right direction there.
Yeah, absolutely. We do. The training that we did recently was we brought together paramedics, local paramedics, nurses at our level 1 trauma center, the residents, and the emergency physicians, and we went through rapid cycle deliberate practice for handoff of a cardiac arrest from pre-hospital to ED. And that was all focused on the teamwork and communication, the handoff, and then repeating that to improve the process. So that, whether it's done in the simulation center or in situ, which is often a little bit easier to do because you have access to all the teams and it's in their clinical environment, that's the kind of simulation-based team training that we need to continue to do.
And I think that's why ACLS training really never was effective, because historically you're going and you're doing your mega code when you become AHA certified alone, right?
Right.
And codes don't work that way. And the errors aren't made when the individual knows the algorithm. It's how that algorithm is communicated to the rest of the team. So important.
Yeah, absolutely. In the VA, when I was there, when we rolled out our READY program, was the Resuscitation Education Initiative. The ACLS was just the beginning. And then there was a whole initiative on Inside 2 code training that would accompany that, which is where you really get the learning. So you're absolutely right.
So before we start wrapping up, I also wanted to give you a chance to plug your own podcast. And I know that ties in exactly to your role at the University of South Florida, working with patient safety and working with interdisciplinary team education. Mm-hmm. So why don't you give a little plug for your own podcast?
I appreciate it. So we started a podcast during the beginning of COVID. The name of the podcast is Healthcare Super Teams. It's available on Spotify, Apple, all the places that you would probably see them. And we now have 3 seasons. We're in the middle of season 3. The first season was really fun. It was really focused on interviewing experts from outside of healthcare that really have these incredible super teams, and then bringing those best practices back into healthcare. So somebody that probably everybody in healthcare simulation recognized is the first person that I interviewed was Ed Salas, who is a team scientist, team expert, and he talked about his time working with the Navy and the military and healthcare as well. But then I was interviewing folks from the CEO of Nestle to a conductor of the New World Symphony to a senior scientist for NASA sending a team to Mars. Incredible discussions and lessons learned about what are they looking for in their super teams, that, why they're so successful. And so bringing those best practices back to healthcare. So that was season 1. Season 2, we looked more at the individual. I interviewed, the focus was on racism and bias in healthcare. And I interviewed individuals from different backgrounds, identity, professions, to really understand their challenges that they've had as representing whatever they identify as. And then successes and really how do you advocate for others that might be in your situation. And somebody that, again, in simulation, probably well recognized, Jen Arnold. Had a pleasure of interviewing her as a little person, her perspective. I mean, her story is amazing, how she got to medical school, overcome a lot of the hurdles, and continues to advocate for little people throughout the country and the world through the work that she's done. And the last person I interviewed was the Assistant Secretary for Health and Human Services, who is openly transgender. Admiral, and she again talked about her experience and just her advocacy around LGBTQ plus communities. And the current season we're focused around is on mental health, wellness, and burnout in healthcare. And so we've been talking to, chief wellness officers to understand how do you create healthy teams through efforts at a hospital system level as well as individual level around this topic, including the very difficult topic around physician suicide and healthcare suicide.
All right, Haru. Well, it's always great to catch up, and it was really great talking to you and hearing about some of the things you're up to.
No, I appreciate it, Jeff. Great to see you. Always appreciate your thoughts and always appreciate your collaboration. So good luck on the podcast, and good luck with all the patient safety efforts at Northwestern.
And good luck running the society and your advocacy.
Thank you.
Thank you for listening today. In our next series of podcasts, we will continue to discuss key aspects of simulation healthcare education with experts in the field. Bye for now.